Good afternoon. My name is Tom Gaze. I'm director of the Rockefeller Institute of Government, and I'm delighted to have you here on this lovely day to the ACA Implementation in New York. Now, many of you probably know some of the basic components of the Affordable Care Act, or I should say the Patient Protection and Affordable Care Act of 2010. It prohibited insurance companies from denying coverage based on pre-existing conditions. It mandated individuals to have health insurance, whether it be public or private, and imposed financial penalties on those who don't comply. It helped those who couldn't afford to pay for their health care plans, up to 400% of the federal poverty level, and it imposed caps on out-of-pocket expenses. And then it created exchanges for individuals to buy health insurance coverage from qualified health plans in what were hoped to be competitive markets. And it did the same for small businesses that seek plans to offer their employees. And finally, it also expanded Medicaid to all persons up to age 65 with income below 138% of the federal poverty level, and it allowed young people up to age 26 to stay on their parents' health care plans. There are a lot of other elements. It's a rather big program. It included cost controls, quality improvement measures, prevention services, health workforce measures, etc. And although it's very difficult to really forecast anything these days in national politics, at the risk of being called a loser for trying to forecast these things, I do expect that the Affordable Care Act will be around for a while, and it'll be a framework for a lot of changes in our healthcare system over just the next years and maybe even multiple decades. Now, that doesn't mean that there's not going to be changes, but my guess is that a lot of the changes are going to be occurring not so much at the national level, but much more at the state level. For that reason, to help keep track of these state-level developments, the Rockefeller Institute and the Brookings Institution have put together what is called the ACA Implementation Research Network, also with help from the University of Pennsylvania. Today's forum will focus on a report from that network, and you can find many other reports, I think 27 other reports from states up on our website at www.rockinst.org. And you will find additional reports in the next several months, and we hope for years, to really understand how these developments are occurring. So our next two speakers, Alice Rivlin and Dick Nathan, will introduce you to this nationwide field network study. Then after that, we're going to have our keynote speaker, Sarah Liebschutz, who will present this 28th state report from our network about New York State. After Sarah's presentation, we're going to have three other panels. One on the New York State experience in implementing the Affordable Care Act from people who've been involved directly in implementing the Affordable Care Act. One on a recent and innovative addition to New York State's ACA system, the Basic Health Program. And then a third panel on local challenges in connecting people with the ACA exchange. Now, it's a long program, so I want to be brief in introductions. There's a lot of smart, knowledgeable, and accomplished people you're going to hear from today. If you want to think more about them or know more about them, we've got bios and a handout that's available to you. And then after the session, you can Google them to your heart's content. So, and find out all kinds of interesting things about them. Right now, though, I'd like everybody to shut down their cell phones. Anything that's likely to beep, ring, play the Fifth Symphony, Taylor Swift, whatever you might have, please shut that down right now. So first up, we're going to have Alice Rivlin and Richard Nathan. I could go on about both of these people for a very long time. I've admired them ever since I was a graduate student many, many years ago, and I read their work. They are great scholars of federalism, great scholars of domestic policy and public finance. They've been distinguished public servants, and they are really founders, essentially founders of great public institutions. In Alice's case, the Congressional Budget Office. In Dick's case, this very institute where you're sitting today. So I'm going to turn it over to them, and they're going to talk about the network, which will put it in context for Sarah to talk about New York. Alice.
Thank you very much, Tom. I'm just delighted to be here. I have worked over many years on a lot of issues that involved national and state policy and federalism issues. And the Rockefeller Institute of Government was always the go-to place for real information about what was going on at the state level. Washington, as you know, passes laws, and then sometimes seems to forget that passing a law is only the first step, that what really happens in many, many cases, in the important things that affect people's lives, like education and healthcare and housing, what really happens at the state level. And it's the implementation of the law that makes it either successful or not. I stress that because many people at think tanks like the one I work at, the Brookings Institution in Washington, don't seem to understand how important the implementation is. Well, we do. We are very fortunate to be partnering with the Rockefeller Institute on a project looking at what is actually happening now that we have passed the Affordable Care Act and it's operating. What is actually happening at the state level? What's working? What's not working? What could be better? And the objective of this project is not just to accumulate knowledge about what's going on at the state level, but to help the states learn from their own experience and from each other how to improve this important law. Now, Dick will talk about the network and how it got started in a little bit more detail. And then we're going to turn to the state of New York, its successes and its challenges. I think you should be very proud of the state of New York in the way that it got the Affordable Care Act started. But there are still major challenges. There are New Yorkers who still don't have health insurance. And the objective will be to think, what can we learn from this experience which will help the policymakers in Albany do a better job in the next few rounds of implementation. Now, the dominant feeling about the Affordable Care Act is it's very complicated. And it is very complicated, and it's very tempting if you're a politician, either of the right or the left, to say, this is so complicated, couldn't we just blow up the whole system and start over? Wouldn't it be simpler if we could just start again and have Medicare for all, for example, or if you're of a more conservative persuasion, the equivalent statement is, wouldn't it be simpler just to have the private sector take over and give everybody a refundable tax credit that they could go out into the market and buy health insurance? It might be simpler. I don't think so. Those of you who implement things think about implementing that. But I'm a budgeteer, and the dominant response, I think, to that kind of thinking is that's not the way we make policy in the United States. We make it very incrementally because, in general, we don't trust government very much. So we kind of sneak up on it and make policy incrementally, and that's the way we like to do it. And that's why we depended very heavily, and still do, on employer-based health insurance coverage, aided by incentives from the tax system. Half the people in the United States, working age, still get their insurance through their employers, and they think that's normal, and they like it. And nothing scares them as much as thinking it might all go away. Then we created Medicare, then we created Medicaid, and then we discovered that we had a whole bunch of people that weren't eligible for anything and were uninsured, and that's how we got the Affordable Care Act. It is complicated to fill in a hole, to patch a patchwork, but that is exactly what we're doing. And to my mind, it is inevitable that we stick with that and that we try to do it well. If we were to blow up the whole system, imagine what the cost of Medicare for all, if it was to replace the employer-based system, or tax credit, which would do the same thing. We have to raise taxes an awful lot, and we're not going to do that. The Affordable Care Act had basically two objectives: to improve the coverage, to move toward universal coverage, and to mitigate the rising cost of health care, which is in the United States very high and troubling, and is driving the projections of federal spending outrunning federal taxes as you look ahead, driving the increase in our debt. So the kinds of questions that our network is going to try to answer, not just how are things working at the state level, but how can we learn from that experience to increase the coverage more and to reduce the rate of growth of costs. And that's where the Affordable Care Act, in its market aspects, really is a hope for the future, that competition among health plans can be sufficiently transparent that citizens can make good choices on an exchange, which you have working well in New York, and that the competition among plans can keep costs from growing too rapidly. I'm not going to say, as some presidents sometimes do, bring them down. Not going to happen. It's the rate of growth of costs that has to be controlled. So this network of states will focus going forward on how can we improve competition in the individual insurance market. What are we learning in all of these states about how it works, and how can we get more people covered? And we'll talk later today about the role of navigators and others, and we need to understand that, what's working well, what isn't, and how can we move that information in the places where it's working well to places where it isn't, and improve the ACA. Let me turn things over to the father of the network, Dick Nathan, and perhaps the father of field research, to be a little more specific about what we're doing. Dick.
Thank you, Alice. The first thing I want to say is that both of us, speaking on behalf of Alice and myself, appreciate the hard work, the continuing work, the seriousness of the work of the Rockefeller Institute Tom Gaze, Bob Bullock, and the staff here have produced a gold mine, a running history of documentation of what decisions were made, who made them, how and why. A rolling history that's in the form that we get all our knowledge now online. There's a map. You can click onto the map and you can read any one of these reports, and they're all organized the same way, so you can look across them and you can read them as a story. We've also issued updates to those reports. I'm here today sort of nostalgic because I began my professional career doing this kind of research at the Brookings Institution. And I spent a long time here, happily and proudly, at the Rockefeller Institute doing similar studies. And a couple of years ago, Mary's here, and she's going to hear this. When I retired, I didn't know what to do with myself. And I decided that I really need something that is new. What I shouldn't do is say I'm going to write about all the things I did and all the people I knew, and hey, look at me, my research, my inside, in and out experience in government. And I don't really know why I came to the decision, but I came to the decision that I would study health reform. What is happening? This is 5 years ago. I knew something about the subject, but not a lot. I know a lot now. And what I want to say about our network is that in 40 states, we have over 100 people who are deeply engaged and really, in many cases, strongly expert on healthcare and on their state and the politics and health policy in their state. And now we're at a phase, as Alice said, where what we're doing is we're going to do multi-state research comparing and particularly focusing in on marketplaces. There are rating systems in every state, rating areas, and within those rating areas, there's competition or there's not competition, where there are multiple plans that have a share of the market, that are competing with each other, that citizens can understand, that bring people into the market and get them to participate in the market and provide them with affordable choices and quality, reasonable quality choices. Now, there's only one way you can find that out, and that is by being out there looking at markets and plans and changes. This is now the 4th enrollment period, starts this fall. Who's going to be offering? What are they going to be offering? What are these plans like? How much pickup is there? And this is really the critical thing, a baseline. Alice and I talked about it this morning, that we want to develop starting in 5 states and expanding to more states in the network. We're working in California, which is out front, Texas, where Mike Morrissey, our field researcher, wrote the book on health insurance, Florida, where the governor doesn't like and the politicians don't like the Affordable Care Act, but the enrollment there is somehow and surprisingly very high, and Michigan. We're going to look at those states in depth and in detail on the ground in the 4th enrollment period, and we're going to tell that story so that after the election, when people say, now what? We will contribute something that needs to be understood from a vantage point that will help people learn as we are going to learn. What's out there, how's it going, what's working. I sometimes call this our Diogenes project, looking for an honest man, but anyway, looking for places where networks work, where the Affordable Care works, and as Alice put it very well, what we can learn from that and help other people because we've learned that. Thank you all for coming.
Okay, I want to now introduce, though still shortly introduce, our next speaker, Sarah Liebschutz. Sarah has been a longtime friend of the Rockefeller Institute. As we were talking just a little while ago, she is one of the earliest participants, or maybe one of the first participants in the field research networks that Dick Nathan has developed, going back to revenue sharing. She is a former professor of political science at SUNY College of Brockport and a distinguished service professor emeritus at SUNY. Her specialization has been in federalism, intergovernmental relations, and New York politics. And I'd really recommend one of her more recent books, Communities in Healthcare, the Rochester, New York Experiment, for those of you who are interested in what a progressive community can do to improve their local health systems. So, Sarah, take it away.
Thank you very much. It's very nice to see some familiar faces here, including my son and my granddaughter, who just got an Master in Public Policy at the Kennedy School. So, and many other friends and familiar faces. Very happy to see you here. Thank you, Tom, for that introduction. Thank you, Dick and Alice, for co-directing this important project. I'm very happy to be a part of it. Now, for many months, I've been focused, my family might even say obsessed, about the implementation of the Affordable Care Act in New York. So you can understand my curiosity about whether the ACA played any role in April when we held the New York presidential primaries. We learned that John Kasich eats pizza with a fork. We learned that Ted Cruz makes matzah. We learned that Hillary Clinton reads her emails on the subway, and that Donald Trump is busying himself with wall designs. I detected no attention to the Affordable Care Act in New York. In fact, over the past 6 years, since the ACA was enacted, television, internet, newspaper features on the ACA in New York have not been totally missing, but they surely have not been prominent. So why is this the case? Let's see if this works. Yes. Okay. Is the Act too complex, too nuanced for the 24/7 world of news? I think the answer is yes. Have there been no scandals, no fraud, waste, and/or abuse involved in New York? Well, we don't generally get high marks for virtue in the New York State government, but that is correct in this case. No scandals. Any partisan divisions in the state legislature worthy of emphasis? Well, that's true, with a few exceptions. I'll tell you about one. Is the New York public sharply divided on the Affordable Care Act? Well, you may be interested to know that actually public support for the Affordable Care Act in New York is at 50%, which is a lot higher than many other states, with only 30% opposed. Distinguishing. But of course, the fact that the public is not sharply divided means that no news is no news. Finally, is it because the Affordable Care Act has been implemented smoothly and skillfully in New York? The answer is yes. That actually is the conclusion of my report. However, so you won't think it's time to get up and leave, please know I'm going to embellish that bottom line. I'm going to build a case with evidence that leads me to that conclusion. But I also want to say right at the start that my approach today is to zoom out on the big picture, as I have come to understand it, not to zoom in on the many details in the report that you can read for yourselves And actually, the panelists are going to supply some details as well. I'm the zoomer out here today. Now, as Dick has mentioned, all of the field researchers focused on decision-making. We had a common format, common list of topics, by state government institutions and actors about two major Affordable Care Act state options for the states. Mounting state insurance marketplaces and expanding Medicaid eligibility. If you look at the table of contents of the New York State report with that and compare that table of contents with any other state report, you'll see a consistency of topics. However, for an individual field researcher, the greater value of the format, this particular format, is that it allows us to explain the uniqueness of our state to make implementation choices in the face of one singular, complicated though it is, one singular federal policy. This common but flexible field researcher format is a hallmark of the work that Dick Nathan pioneered and refined. And of course, I am very honored to have been associated with Dick from the beginning. Dick and I share a birthday. Maybe that's the magic here. I don't know. But the bottom line here is that New York, in some ways, is like other states in its implementation choices, but in other ways, it's quite distinctive. I have a caveat to issue before I set the stage. Of course, I am aware that ACA implementation choices and actions are not the only issues of interest or advocacy in New York. Universal health care through a single payer program, the Assembly has passed such a plan twice. Medicare for all plans, tax credits with private insurers, delivery reform, assuring integrated, cost-effective quality of care. All of these come to mind. They all deserve attention. They all deserve careful study. But my research, my emphasis, as well as the focus of the participants in this conference today, and I trust your focus of attention, will be the implementation of the Affordable Care Act in New York. Now, New York is a progressive state. It's a blue state. It's a state that has embraced healthcare reform for many decades, way ahead of the rest of the country. A state whose decisions to establish a state insurance exchange and to expand Medicaid eligibility seem unremarkable. Unremarkable. Maybe. Inevitable? No. Background matters. First, I would point out what I have called a paradoxical political culture. It's not trivial. It is not a trivial matter at all that the decisions of New York affirming the ACA were and are compatible with the state's political culture. New York's political culture is progressive, all right, but it is also competitive. That's why I call it paradoxical. The New York character, if you don't mind my quoting myself, contains two dominant values: individual entrepreneurship and collective benevolence. New Yorkers generally believe that government should facilitate individual endeavors. At the same time, they generally have shown a spirit of tolerance, even though they haven't necessarily loved each other. Three influential decisions were made either before the ACA or concurrent with it. I just want to mention them briefly. A pre-Affordable Care Act decision involved the use of federal waivers to expand income eligibility to Medicaid for parents and single and childless adults. This turned out to be a precursor to expanded Medicaid eligibility in New York under the Affordable Care Act. Another decision was to centralize and computerize Medicaid eligibility at the state level. In other words, to take it over from the New York City Health and Human Services Administration and from local county departments of social services. The process was highly individualized, some people doing intake, paper and pencil, others more computerized. Anyway, the ACA actually prompted that decision. A centralized intake function was seen as an opportunity to develop a system that would facilitate application processing under the state-based exchange. And the third decision that I would note was to create the Medicaid redesign team. This was the most visible, I think, publicly of these three decisions that I'm just briefly discussing. This was Governor Andrew Cuomo's creation by executive order, just days after he was inaugurated, of a Medicaid redesign team charged with restructuring New York's high-cost Medicaid program to achieve measurable improvement in health outcomes, sustainable cost control, and administrative efficiency. All three of these major decisions helped New York to exercise the important option of mounting a health exchange and expanding Medicaid eligibility. I'll return in a minute to something else that all three decisions had in common. But I would also point out that New York had in place statewide health partnerships that had long been established. The report lists some 15 major such partnerships representing consumers, providers, insurers, businesses, as well as funders, all of whom were eager for information and poised to work with state agencies in implementing the Affordable Care Act. Their constituent bases certainly differed, but they shared a strong interest in how the ACA would play out in New York. And as you'll learn in a later panel, they really were critical, really at the ground level, in reaching out to and assisting New Yorkers throughout the state to enroll on the state insurance exchange. It is not accidental that the three decisions made by the state government all involved Medicaid. And what's further significant about this is that Medicaid, federal Medicaid revenues play a very important role in New York's Medicaid program. So let me just say a few words about the importance of federal funds. For at least 50 years, New York has been very aggressive in seeking federal funds, particularly for public health programs. For example, in 1965, immediately after Medicaid was enacted by the Congress, Governor Nelson Rockefeller seized the opportunity for New York to participate. He viewed Medicaid as a vehicle with which both to expand health services and to obtain larger, much larger amounts of federal aid than were available to New York under prior public health programs. The state government also saw and seized opportunities for federal ACA funds to lay the groundwork for a state-based exchange. A $1 million federal exchange planning grant to the Department of Insurance, one of the precursors of the Department of Financial Services in our state, in 2010, was the first of several federal grants to New York to develop the exchange. By early 2012, such federal grants totaled $88 million, and by mid-2014, they totaled over nearly $600 million federal dollars. New York likes federal funds. One of the first decisions, let me get this, no, this. All right. One of the first decisions in establishing the exchange, called the New York State of Health, was where to locate it. And that is one of the very few issues that I could find, and I probed pretty hard, that was mired a little bit of time, a couple years actually, in partisan divisions. First, the governor proposed in a program bill to the legislature in 2011, and then included in the executive budget for 2012-2013, placing the exchange in a new independent public authority. The Assembly majority approved. The Senate Republican authority did not. After negotiations with the leaders of the Senate Republican majority and the Democratic majority of the Assembly, the new framework, the new location for the state exchange was within the existing State Department of Health. According to many people whom I interviewed, that turned out to be really a good decision. They were working with people whom they knew, had common experience and common background, worked out very, very well. The framework for the new exchange in the governor's executive order included not only its location, but its authority, Department of Health, to work with the Department of Financial Services, I'll come back to that in a minute, and the appointment of Donna Frescatore, who's with us today as the executive director of the exchange. The New York State of Health is an individual, integrated marketplace. Integrated meaning Medicaid, Child Health Plus, both of which are public programs, and qualified health plan insurance. Come back to that in a minute. And also a small business exchange called the SHOP, offering health insurance to employers with under 50 employees. Okay, that's the fundamental framework. Immediately, there were some operational challenges with respect to some division in authority between the Department of Health and the Department of Financial Services. The Department of Health has responsibility for development of the website, information systems capability, program articulation among all these programs, and training of navigators and brokers. Brokers are the so-called navigators of the SHOP, and the navigators work with the integrated individual marketplace. The division of the Department of Financial Services is responsible for health insurance regulations, including rate setting and financial solvency of private or nonprofit insurers offering insurance policies called qualified health plans. I refer you, when you have time, to look at Section 2.7 of the report for details on what we call the QHPs. Now, bureaucracies are frequently characterized as slow and resistant to change. But in this case, highly responsible directors and staff in each department, working either in inter or intra-departmental teams, worked really hard and collaboratively. I heard those terms used over and over with the people I interviewed, to simultaneously build the IT platform for the exchange and to centralize Medicaid eligibility. Further, were disagreements between the Department of Financial Services and insurers involved, what else? Insurance rates. Donna Frescatore was commended over and over for her practice of meeting frequently with insurer CEOs, and that was very effective in overcoming any problems. The technological problems were just as daunting, maybe even more so. Developing the IT infrastructure, operating the exchange, responding to volume overload. Many consultants were involved in building the state exchange. Computer Services Corporation, CSC, was the lead developer for the integrated marketplace as well as for Medicaid centralization, and it continues to have responsibility for the operation of the state-based exchange. When the marketplace opened for business on October 1st, 2013, it was overwhelmed by volume. People accessing the internet, accessing the platform in the first 3 days of operation for information to enroll. Anyway, by the fourth day, these problems were absolutely resolved by quadrupling IT capacity held in reserve for future Medicaid expansion. One person whom I interviewed about the successful story of the New York State of Health commented simply, she said, the answer is the technology worked. Unlike many states, those with state-based exchanges and those that use the federal exchange, that experienced highly publicized glitches that many people running for office just glommed onto and said, oh, this is a big failure, it's just terrible, terrible. The New York Exchange, I'm very happy to report, has operated smoothly and skillfully through 3 years of operation. It's a real success story. Now, let's just move for a moment to talk about enrollment on the exchange. And what I would say is that the Urban Institute developed projections for many states, including New York, in terms of how many people would purchase their insurance, the private insurance, and they estimated, you can read, about 200,000 a year with a total of 615,000. New York way exceeded those numbers, so that at the end, this is just for the qualified health plans, over 1 million people. The third year was marked by the addition of a basic health program called the Essential Program in New York. We have a whole panel devoted to that topic. This is an option to Medicaid, the qualified health plans, and child health programs. It's a very interesting program for its attractiveness to both legally residing non-citizens and its very rich federal reimbursement. By the end of the 2016 open enrollment period, nearly 400,000 individuals were enrolled in the Essential Plan. So let me just show you the total enrollment for the individual programs, including in the third year, the Essential Plan. And you can see slightly under 1 million for the first year, doubled in the second year, and up by 700,000 in the third year. So by the end of the third year, more than 2.8 million New Yorkers had enrolled in the insurance programs offered on the New York State of Health marketplace. And another interesting point, I couldn't get the up-to-date figures on this, but in October 2013, when the exchange opened, it was estimated that slightly under 13% of New York residents were uninsured. 6 months later, after the first open enrollment period, that number had fallen to about 13%, and 1 year later to about 8%. I don't have the figures for the present time, but I'm sure it's dropped more. I want to circle back to something that I said at the very beginning, and I know that my time is running out, but this is a big topic. So, Bob, you'll have to indulge me 2 more minutes. So I began my talk by rejecting the premise that New York choices and actions to mount a state insurance marketplace and expand Medicaid eligibility were inevitable. I don't agree, was not inevitable. Yes. The background that I presented to you, important but not sufficient to explain why New York was able to meet the technological and institutional and partisan challenges that every single state faced in implementing the Affordable Care Act. Stable and energetic leadership. Stable and energetic leadership. Absolutely critical, the necessary central feature in implementing the Affordable Care Act in New York. From Governor Cuomo's decisive commitment made early in his administration, his flexibility in locating it in the Department of Health, and I'm really running out of adjectives here, but I'm going to give you the list. Dedicated, experienced, intelligent, nimble, and accessible directors of the exchange. They're sitting here right in front of me, and of their collaborative colleagues in the Department of Health, particularly the Medicaid division people, and in the Department of Financial Services, made the difference. New York State leaders affirmed state options early. They acted with all deliberate speed to improve access and hopefully quality and cost savings. Influenced by past experience, they enhanced the Affordable Care Act implementation through their partnerships with statewide nonprofit organizations. It has been an enormous privilege for me to have come to know these leaders, to appreciate their openness to my questions. I was the student, they were the professors, and I am optimistic that nimble, adaptable, and knowledgeable behavior and impressive outcomes to New Yorkers will continue to mark the implementation of the Affordable Care Act in our state. Thank you.
Well, thank you, Sarah. And now I would like our nimble, intelligent, and dedicated leaders, Donna and Judith, Donna Frescatore and Judith Arnold, to come up here. Donna is Executive Director of the New York State of Health. Judith Arnold is Director of Medicaid Eligibility and Marketplace Integration. And what we're going to do, we're going to have these two individuals, we're going to have a conversation for a while, then we're going to bring up Dick and Alice a little bit later, and then Sarah and Dick and Alice later. And at that point, after that, we will have Q&A. So we're not going to have Q&A right now. So, Donna and Judith, we should forgive them if they're blushing. But in any event, I'd be interested if you have any things to add to that or subtract if you wish. But basically, I wonder if we could just start off, you could talk about what do you think have been the most important accomplishments so far in the state's implementation of the ACA, but also just reflect on where you still think we have a lot of work to do. And it's a big state. I suspect there is some work to do somewhere that your job is not over yet. And either one of you can start. Donna, do you want to begin?
Great, sure. Thank you. Thank you, Tom. Thank you, Dick. It's good to meet you. And Alice, thank you. Sarah, we're humbled by your remarks. Thank you so very much. It's been I think we would all say it's been an amazing journey over the last several years. And I've said it a number of times that, this would not have been possible in a state where we didn't have the support of so very, very many, not only organizations, but individuals who committed themselves either by joining our staff, in their everyday work, and their willingness to collaborate. And we know there's things, certainly, Tom, as you said, left to do. But collectively, we've done a lot, and we're very appreciative of that. I don't think we ever take that for granted. It's made a world of difference to New York's consumers. So, I think the top line achievement is, Sarah, we had a chance to look at some updated figures from the Center for Disease Control Prevention, and using their comparable numbers of uninsured from 2013 till the end of December 2015, the rate of uninsured in New York is about half of what it was. That translates to 900,000 people having insurance as of the end of December that did not have insurance when we began this project in 2013. And I think it's a testament to everyone who had any role in doing this. I think the other benefit is, thank you, is that, in addition to just the sheer number, just the awareness of the importance of having health coverage is just tremendous. I mean, you've all experienced this. You're standing in a restaurant at the hostess stand, and that's what folks are talking about. You're in a cab, and people are talking about insurance. I mean, it's just quite phenomenal. I was in an event that wasn't work-related last week, and I was sitting with a woman I'd never met before, and she said, what do you do? And, we're a little hesitant at points to answer that, right? Say, I work for the state, and, and because you weren't really sure where people were going to fall out on this. And when I told her, what I did, she said, my physician said that we really didn't need the Affordable Care Act in New York. We were already there. And in some respects, we were. Through the wisdom, I think, of leaders, the wisdom of our legislature, people could access insurance. People weren't denied coverage because of pre-existing conditions. There was, a very robust small group market. Individuals market was tougher, right? It was more costly. So I suggested to the woman that next time she have a visit that she remind her physician that 900,000 more people had health insurance, and she said, really? So maybe we could do a little bit better job in getting that across. And then, the other thing is, I think together we fundamentally changed the way people go about buying their health insurance or enrolling. I mean, I think it wasn't that long ago, and this was something Judy talked about. Judy and I have worked together since 1998 in various capacities, and Judy talked about this all the time, that people had to go to government to get health insurance. I mean, when you think about it, we don't have to go to an office for most things in this day and age. So we've been able to bring insurance, I think, to people, whether it's through the website, through thousands of people who are in our communities representing really this program on the front lines, and to them, you're going to hear from some folks later. We owe them a tremendous amount of credit for how they represent these programs.
Very good. Judith?
What I'd like to add to what Donna said, which I agree 100% with everything she said, is the importance of our decision to create an integrated marketplace. It seems like such a no-brainer, and I think Sarah did a nice job sort of outlining our incremental approach and the leadership and how we got here and how the decisions looked simple. And they were. I mean, we didn't even, among us, it wasn't even a question mark about whether our marketplace would have Medicaid CHIP and the tax credits and the full pay QHPs and now Essential Plan all in one place. But it was really huge, and it was really hard. It was a lot harder to be an integrated marketplace. It still is. Than I think a state who chose just to set up the marketplace for just the QHPs and refer their Medicaid people to the local districts or the state Medicaid office or however the state is structured. It was a big, big deal, and I look at that as one of our major accomplishments, in addition to enrollment and in addition to reducing the number of uninsured. I mean, if you think about it, we had Medicaid and CHIP, and you used to apply for Medicaid at the local district, and then if your kid wasn't eligible for Medicaid, you had to start all over again and apply with a different application for CHIP. That wasn't that long ago. If you think about it, now you can come online and you can get whichever you're eligible for. It's one application. Families can have 3 eligibility determinations within the family. And that's really was game changing. I mean, in so many ways, our notices now have all the programs together. They're too long, but that's why they have all the programs together and all the things everyone's eligible for. And the feds make us also tell you everything you're not eligible for, which is very long, because you're by definition not eligible for all the things that are different from what you're eligible for. And so it's just been, but it's also been really hard, and I think that still remains how to be fully integrated, how to achieve that whole full integration experience. So there's seamless transitions between programs. The feds haven't made it easy. I mean, that's been one of my disappointments is, the regs that have been developed in very siloed, by the IRS, by SSIO, by CMCS, and they don't interact. We interact way better at the state across our different offices. And so the rules are really different across the programs. And I think Alice made the point how it's complicated. The eligibility rules are way more complicated than they were before the ACA. That's one disappointment. I mean, they kept talking about simplification. Simplification is not simplification, but it is automation. If you can automate the complexity, you've simplified it for the consumer. So I think that's our accomplishment, and we still have more work to do on fully realizing integration.
Interesting. Well, one of the things I thought that ACA was trying to do was try to simplify at least Medicaid. Do you feel like there was any effort, that there was any progress on the simplification of Medicaid eligibility?
Yes.
Okay.
Yes and no. Yeah.
Couldn't have gotten more.
I would say yes. The biggest area of simplification of Medicaid was by reducing the number of categories. So I think prior to the ACA, New York had about 80 categories of Medicaid eligibility that you could fit in. And I haven't counted them since, but under the MAGI rules, which is the eligibility rules for the people that can be determined under modified adjusted gross income, those rules have fewer categories. There's basically, the new adult group collapsed a lot of people into the adult group. So in the category area, that was major simplification. I often, thank you for that question, because I often lose track of it. In terms of the eligibility rules changed in that we're now basing it on tax households. And so there's essentially two eligibility, whether you file taxes or you don't. For a Medicaid person, you have different rules. So that's an area of complexity that's new. So there's new complexity, but the category shrinking was a major simplification.
Okay, good. Well, were there any surprises that you sort of seen so far in the last 3 years that you didn't expect? I know you all did wonderful planning, but no matter how good one plans, there's usually something that pops up that's surprising. I don't know whether the size, a lot of the people coming on that have been newly insured have been using Medicaid. I don't know whether you expected that to be so large. Maybe you did, or were there any other surprises that and how you dealt with them or thinking about them? So.
Yeah, Tom, that's a great question. I was asked that early in the implementation when I was interviewed by a reporter. And, I think today my answer might be exactly the same as it was then. And what surprised me initially, in addition to all the media attention around it, quite frankly, but what surprised me initially still surprises me today, and that's just the sheer demand and volume. 1.8 million people visiting the website during the last open enrollment period. That's unique visitors. We answered 1.3 million calls in the call center. We did 1,400 outreach events. So the demand is there, and it continues. And the Essential Plan, I think, has renewed the demand. And I know you all are going to talk about that this afternoon. And it's an amazing program for consumers. It's changed in some ways the way we think about open enrollment, since it's open all year long. Credit goes to many in the room who advocated and saw the opportunity early on in the planning of the Affordable Care Act. So while, we didn't do that on day one, it was certainly in the back of our minds as we took the implementation steps along the way. So volume continues to surprise me. Fortunately, I'd say no giant surprises, no big surprises on governance structure, little surprises, every day, many times a week that we learn from. And I think that's our challenge. Part of our challenge now is to learn from what happens day to day, and we learn from everyone. We learn from our sisters, we learn from our consumers, we learn from our customer service representatives. And there are days that everyone has something to teach us about how to make this better. And so that's what we're really in tune to now, is how to refine process and procedure from the consumer's vantage point.
Okay.
Let me just speak a moment to the Medicaid enrollment and kind of explain why we weren't surprised by that. In a sense, it's the bringing together, the launching of the ACA with the centralization of the state administration of Medicaid eligibility, which we chose for logical reasons to start with the MAGI population. So as of January 1st, 2014, anybody who was newly applying for Medicaid needed to apply through us. So we shifted a lot of people from the local districts over to New York State of Health, so some were known to Medicaid, and that the Medicaid population, people go on and off Medicaid. So it's not like they were brand new. Then we had brand new people. We had the newly eligible through the expansion, which because of our waiver, our expansion was small in New York, but it was still about 10% of our Medicaid population is the expansion. So it was significant, and something that no one's really paid any attention to is the differences in the MAGI rules, and that they actually raised the amount of income people can have to be in Medicaid.
Could you describe what MAGI means for the rest
it's modified. It stands for Modified Adjusted Gross Income, and there's now in the Medicaid world now with the rules, CMS defines it as there's non-MAGI rules and MAGI rules. And there's categories of people that get their eligibility determined under MAGI rules. And the MAGI rules govern the marketplace, essentially. The local districts, they have a little of it, but they mostly have the non-MAGI people still. And so those are people that you're basing their eligibility largely on their taxes, their tax household, their tax income, and what that did was from the past, it took away all the deductions. So it basically said Medicaid used to start with income and then you'd go down and then you'd have Medicaid income. And that was called net income. I know no one lives in the eligibility weeds like I do. What the ACA did was it said, we're going to get rid of deductions and allow you to have gross income. But in the weeds of that, it also said there's a bunch of income that isn't going to count. If you don't count it on your taxes, it doesn't count as income. A big example of that is workers' compensation. In the old days, if you lived off workers' compensation, that counted as income, and many people were not eligible for Medicaid because their workers' comp put them over. Today, if that's your only income, it's like you have zero income. So within the details of the rule, there's the newly eligible, then there's people we shifted from the district, but then there's a whole cohort of people who were newly eligible, but because the rules made their income be able to be a little higher. So their income may be below 100, which was where we were, but they weren't under the way we did the old rules. I know that's very complicated, but it represented a large portion of people who could now come in because we count their income differently.
Right. Now, are there identifiable groups that we're just still not reaching nearly as well as you'd like? We have an integrated wide array of programs here in New York State, or is this the group of programs needed to reach them, and we just have to use them better and administer them better to try to reach down further and increase enrollments among these identifiable groups? So,
I think the essential plan, which we don't want to steal the thunder of the people coming next, but that has reached, I think, a lot of people who were, it moved some people from Medicaid or QHPs into essential plan, but it also reached brand new people who felt the QHPs were too expensive. So I think that did a good job reaching people we might not have been reaching. And I think there's still people who believe the qualified health plans are too expensive. And we try everything, and I don't want to steal Donna's thunder, but we try everything to reach them, and there's still a group that will maintain that view.
Okay.
Yeah, if I could, Tom, just to add on, one of the things that I think we've quite honestly gotten better at over time is working in communities. I think our first year open enrollment, while successful, I think everyone was learning a new IT system. Everyone was learning new rules to the extent they needed to. In retrospect, are there things that had timing been different, we would have done differently, certainly. And Sarah, you talk about one of these in the report, I think you zeroed right in on it, is we had very little time to be hands-on with a new IT infrastructure before we launched. And that was part just the timing, part the complexity of the build. In an ideal world, we would have had months to have our sisters, for our own staff, to be able to work within a brand new IT system. So we were able to, I think as subsequent open enrollments, we've been able to give more time, thought, resources to outreach. And we've been focused, I think, on a couple of groups. One is younger adults, and I think Danielle will tell you how the Essential Plan has moved us deeper into enrollment of younger adults, but also into certain communities throughout the state, including the Latino community. We do an array of presentations in communities. We did a presentation, our first small business presentation last week in Mandarin, for a group in Queens. And so that's really what we're focused on. And we have outreach people who have been very innovative. They're thinking about things like backpack programs where information goes into a child's backpack to go home. We've had the cooperation of a number of pharmacy chains, supermarket chains, other retail chains to get into communities throughout the state. And we're getting good feedback on those events. Our sisters help us by evaluating those sponsorships, see what works, see what doesn't work. And I think we've learned certainly from other states as well in how they do that.
That's wonderful. Now, one of the things in the ACA, of course, is that there's an expectation of competition among plans, qualified health plans. And New York has a lot of plans statewide. But I was wondering if you think that, are you satisfied with the level of competition, in individual or markets? Are there parts of the state where there really is not the kind of competition you'd like to see? I know some of the states that we've been dealing with, there are some sort of localized monopolies in terms of plans. Are we seeing that or anything approaching that in New York or any other kinds of issues with respect to competition or choice so far?
Yeah, that's kind of a very current topic. A couple years ago, the Kaiser Foundation found that New York's marketplace was the most competitive in the nation, in part because of plan choice. That was one of our goals. When you look back at the goals that we set and the objectives for how we would go about selecting which of the health plans would be offered on the marketplace, choice was really at the top of the list, that consumers would have choice. And the balance with choice is that, it makes it more complex. The more things are to choose from, the more complex it becomes. And so there's a balance there. There's a balance on standardizing benefits versus allowing health plans to offer whatever benefit they think is the most marketable or best meets the needs of the geographic area. So for the most part, we follow, along a pattern where there's the most choice of health plan in New York City. That's just true based on how the health plans are licensed. We have some counties that have only 2 health plans, but for the most part, there's choice of more than 2 plans in most parts of the state. And one of the reasons is that we're often compared with California, the California marketplace, where they sort of add another level of regulation. In California, the state insurance superintendent, who's separately elected, doesn't have prior approval of premium rates the way the superintendent here does in New York State under state law. And so the marketplace in California takes another step that some describe as more aggressive selective contracting. And again, we think that's the balance there. We want to make sure people have choice, and we also want to make certain that going forward that there is competition among the health plans and that there's ways for consumers to make an apples to apples comparison of those plan choices.
Okay, very good. I guess the other thing, I mean, there was a lot of concern, and I suppose the opponents were particularly concerned about this. They thought that, yeah, people are going to get enrolled, but maybe they're not going to make their payments. They're going to drop out, maybe even very quickly, and you just won't have that much persistence. Do you see much of that as a problem, either statewide or particular areas or particular groups of people? And do we actually have pretty good measures of that?
Yeah, we began probably sometime last year doing some internal reporting where we look at enrollment as of a certain month, and then we follow that cohort of enrollment in time, usually 6 months later, and look. And what we see is there is some drop-off. There are people who don't continue their coverage. We're working right now on some survey instruments that will help us understand that. We know anecdotally that there are some people who don't either make their initial payment or they don't continue to make their premium payment. We also know that there are people who call us and tell us they got a job that has coverage, or they've satisfied a waiting period for their coverage. I see some of our sisters shaking their head because they talk to these consumers. So we want to better understand that, and we also, because it helps us understand if it's possible to change products or change process to help people stay engaged. The other thing that we've begun to look into is the issue of people who go all the way through the application process, get an eligibility determination, but for some reason just don't go on to enroll. And a first look, and I don't think this will surprise anyone, that the first look at that, the results is that, it's about the affordability of products and about how easy it is to select a health plan, including understanding the provider networks. So along those lines, we're working also on a project right now to create a new provider directory system for New Yorkers that would be available not only while you're applying through the marketplace, but the goal is to have it public-facing. So as a consumer, whether you're in the marketplace or not, me as a state employee, I don't have to go to 3 or 4 different URLs to look at the physician. We've got a ways to go there, but we think that conceptually, with the input of a lot of stakeholder groups, that we've got a model that's really going to make it more transparent and easier for consumers to understand and use their benefits.
Excellent. Okay. I guess along those lines, are you concerned? I mean, some places are a little concerned about the narrowing of networks. Is that, do you see much of that? And is there, and I know, network, it's sort of a hard balance, really. On the one hand, plans may want to narrow networks in order to keep costs down. On the other hand, that might make it more difficult for some of the individuals in the plan to actually get their doctors and to and go to the hospitals. How are you seeing that balance playing out right now?
Yeah, so there's it certainly is an issue that gets a lot of attention, and what consumers mostly call us about is that they have a particular physician or a particular provider that they want to see, and they want help deciding figuring out which of the networks folks are in. Directly, consumers don't come to us really on the narrow network issue.
Yeah.
And what I think we see is a variety of network configurations across health plans. There's some plans that use, more robust networks. There are some plans that use the same provider network for all of the products they offer on the marketplace. And then there's some health plans, and this is kind of consistent with the accountable care organization concept, that the networks are they're organized around a healthcare delivery system, and so by their very nature are more limited. What we want to do is make those network differences transparent, and we apply adequacy standards to all of the networks. That's an area I think where we'll, in the upcoming months, along with stakeholders in the Department of Financial Services, be looking at how those network adequacy standards should be changed over time or modified, whether they're provider counts or time and distance standards to providers. And that really fits hand in hand with a new directory system that gives us the flexibility to do those measurements and present that information in a way that's more understandable.
Right. No, that's a great point about if we're going to move towards accountability of accountable care organizations that really break down these silos. There really are a different being out there, and people can choose among them, but not necessarily among the persons, the individual institutions or doctors on their own. Very good. I would like to bring up now the rest of our panel, Dick, Sarah, Alice. So While they're coming up, I have one other little question. Right now, we've seen unemployment decline from very high levels several years ago, about close to 10%, down to 4.7%. Some economists think that that is pretty much full employment. I'm not sure if that's true or not, but it's sort of a sense of, it's their sense that this is good enough. Is there a level at which uninsurance is good enough? I mean, when you think that we've done about just as much as you can, and there are some people you're just not going to be reaching. So, and we will not hold you to this. We just want a way of thinking about how this issue is, how this issue can be played out.
I don't know that there is. I don't know that we've ever set out to say, this is an insurance rate that's low enough. And the CDC results are they came in from the last survey at 4.9%, down from 9.6% or so in 2013. Is 3% good? Is 2% good? I think we're really focused on and really seeing how low we can really get that rate, not only through the existing programs and rules, but to work collaboratively with stakeholders, with the legislature, see if there's other ways to reach people who we've not yet reached with insurance. Judy, if you have something to add?
No, I would just echo what Donna said and say, I think we just need to keep trying to get lower, but I don't think it can be zero. And I don't think and it's not that we can't reach everyone, it's that surveys, a survey is always going to be imperfect. And we have churning in between. You might be insured for 6 months and uninsured for 2 and then back for 4. So there's always going to be some noise that it will never get to zero. But I think but I don't have a statement of what amount I would say I'm comfortable with. I don't think there is that number. I think you just keep trying to get it to get as low as possible.
Okay. Alice, Dick, and Sarah, I'd like to start with Alice, I think. Are there any questions that you'd have either through these or any comments that you'd like to make to add to the conversation?
Well, my main comment is this is very interesting and I've learned a lot. But the question that I had was one that builds on the one that you asked a minute ago. And that is, it isn't just a question of how low you can get the uninsurance rate. It's a question of who's not insured. And in many other states, we've found a lot of concern with the group that's sometimes called the young invincibles, young people who think nothing bad can ever happen to them, and why do I need health insurance? Of course, bad things don't happen to them very often, so they don't have high health care spending, and that's why we need them in the health care pool. If they're not there, other things being equal, premiums will be higher for the rest of the population. But is there a concern in New York that you're not reaching people who just don't want insurance because they don't think they need it? And if so, is there a way to do that?
You're still on, yes. So, sorry, Donna.
No, that's okay. I'm happy to tell Alice. How we've thought about this. There's many groups, including the Young Invincibles nationally, who I think have done some great thinking about this. We've talked to other states and worked with our colleagues in those states on how to reach those younger adults. And we use social media. We try to target events to younger adults. One thing that's looking like it makes a difference is premium. And Danielle's going to tell you a little bit about what we see with the Essential Plan. And, I think when we start to look at some of the information out there, affordability is not just unique to the young adults. It's across the board. And I think affordability includes not only premium costs, but includes out-of-pocket costs. And some of the things that we saw from some other research that, after you see it, it's kind of like, oh, yeah. And that is that not only might a young invincible or someone else think I'm not likely to get sick, but they have perhaps ways to get, or they believe they have ways to get the services that they need on a sliding scale based on their income. And so the idea of insurance really competes, in effect, with the ability to get a service at a reduced rate based on income from a clinic or from some other type of provider. So I think it's been a challenge. We've since the beginning, we've had the percentage of people who are under age 34, so 19 to 34 in New York, has been slightly higher than the national average, but not appreciably higher.
Good. Richard.
I'd like to ask Donna and Judy a question. This was really terrific to hear from you and to get this report. And Sarah worked hard on it. We are very appreciative and glad to have your help and have you here. Donna, when I look at the Kaiser Family Foundation numbers and what the percentage of participation is compared to the percentage or the number of people that, according to the way they use the numbers, are eligible. So this is a scorekeeper's question. When you look at the Kaiser Family Foundation scorekeeping, which a lot of people use, and I know it's made complicated now even more so by what we're going to talk about in a few minutes, the Essential Health Plan.
Yeah.
But New York is kind of middling, a little below the national average when you look at how they keep score. And each time Sarah brings it up and I scratch my head about it, the Urban Institute numbers are telling us something. How should I understand and think about New York in relation to the way the Kaiser Family Foundation does scorekeeping?
Dick, I don't know if I can answer that directly. Danielle's our scorekeeper, so she may be able to answer that in an upcoming session. I think that some of the challenge with the counts and the numbers and the percentages, and I think you heard it right here today, depend on starting points and methods. And so that's been, I think, some of the things that are complicated to message publicly as well. Is the uninsured rate? Who do you include in it? What's the source? What's the starting point? Does it include elderly adults, non-elderly adults? So I know that's not a very direct answer to you. The modeling was intended for us to use to guide our planning. And from the Urban Institute, and we think we've been fairly on target with that. I don't know. I'll defer to Danielle if she has other comments. Maybe later in the session.
Sure, that would be good. So, Sarah.
Well, I actually am raising something that I deliberately stayed away from in my keynote address, and that was to talk about the small business exchange, because I just simply couldn't cover everything. And what I know is that as of a year ago, there were approximately 15,000 employees covered, and I thought to myself, 15,000 compared with 3 million. I'm just going to refer people to what I've written about the shop. But I wonder if some of the issues that I learned of, namely that brokers are not the same as personal assisters or navigators, and that dealing with employers of small businesses is not the same as dealing with people who don't have insurance or want to get better rates, individuals. What you would say about the performance of the shop?
So we started with the premise for shop that it was unlike the individual market. It would be an alternative for small employers. We already had a very robust small group market in New York. 90% of the small businesses that purchased insurance used the assistance of an insurance broker or agent that was licensed by the Department of Financial Services in New York. And so we looked at it as an alternative that was really focused on very small businesses, and that turned out to be the case, kind of micro businesses, fewer than 5 employees, who would qualify for tax credits. Mm-hmm. And the value proposition on the Small Business Exchange was sort of focused on those issues. Eligible for the tax credits, mm-hmm. Because not only of the size of the employer, but of the average wages, $50,000 or less, not including the owner's salary, and the ability for an employer to allow employees to choose an option. So that the employer, instead of saying, this is the health plan all my 20 employees have to enroll in, they would actually have a menu of choices that the employee could choose what best met their needs. And then we coupled that with a couple of things that were different than the outside small group market, which is the employer does not have to make a contribution towards the cost of coverage. Right. And there was no minimum participation rate. So what we found would happen in the small group market, for those of you who are familiar with it or work with it, you might be an employer with 10 employees, which makes you certainly a small employer. But it might turn out that only 2 employees need coverage because they're accessing coverage through a spouse or a domestic partner, or maybe they're still a dependent on someone's policy in some way, shape, or form. And because less than 50% of the employees of that employer were going to enroll, an insurer would not underwrite that group because the minimum participation rates were not achieved. So what we see is that it is an option. We increased the small group size to 100.
Has that made a difference? Has that made a difference?
It's made a marginal difference so far. We haven't gone through a full year of renewals in the small group market to see how that changes. But enrollment's relatively constant. I think that despite certainly the numbers are very, very small compared to the individual market, it is, the last time I looked, the largest SHOP enrollment in the nation. Including even states that had a head start on small group exchanges. Like Utah had a small group exchange in place before the ACA. The other thing I would point out, and this, it goes to the Urban Institute numbers, is that the original projection for the small group was in the 400,000 range. It assumed Healthy New York no longer existed for small business, though there was an assumption at the time. The Healthy New York program sunset for individuals on January 1st, 2014, but not for small businesses, so that's still available to a small business if that works for them.
Okay. We're going to turn over to audience Q&A in just a minute, but I have one last question. So, we have a network, and the Rockefeller Institute also does other work on public policy research, as well as many other universities around the state. And I was just wondering, are there issues or questions that you have that you think that our network could fruitfully study that would be useful to you, or that would be useful even within the context of New York State alone? Kind of research that you think would actually be really helpful for achieving the goals of the ACA. So.
No, I don't know, Tom, that I have a specific suggestion, but, I think more and more, we want to understand how the ACA has affected consumers directly. And so the type of research that helps us understand consumer behaviors, their choices, what's easy for them, what makes them stay out of the insurance game, whether it is affordability, whether it is they don't think they're going to ever need insurance, I think are all things that are really of interest to us because it helps us, define the products going forward. It helps us make changes to the extent we can to reach those residual uninsured in the state. That would be my first thought.
All right, very good. Judith, do you have anything to add?
No, that's a good one.
Okay.
Particularly, one of the things we were interested in is how consumers make plan choices.
Yeah.
So it fits in Donna's bucket, but I'll call it out separately.
Yeah.
Which is when they see their choices on the website, what do they need to have that boil down for them to make better choices?
Okay, excellent.
I would second. I think, Judy, that's a good refinement of what I said. And, we invest a lot of time and resources. There's just a whole new HHS quality scoring system. Our early look is that consumers that's not the top thing they're looking at is the quality score of a health plan. Should it be? Maybe. Maybe if it was easier to understand, it could be.
Yeah.
But I think that's a good refinement.
Excellent. Okay, good. All right. Well, everybody, if anybody has some questions. Bob, how long do we have for Q&A? 15, okay, excellent. So there's a lot of, let's make them questions if possible. If you have a comment, keep it short. No long lectures, please. Yes, sir.
Hi.
Oh, and please identify yourself. And we're going to. Okay, I would ask you that, and you're going to talk in that microphone too.
Hi, my name's Alan Pfeffer. Today I'm a healthcare advocate, but once upon a time I was part of the Department of Social Services team that maximized federal revenue. We were very good at it, to the tune of billions of dollars. But I want to kind of follow up on two themes that have been alluded to in the last few minutes, Tom. The question that you asked about networks. A couple of weeks ago, the New York Times did a story that to the theme of insurance doesn't equal health care delivery. And they focused on, particularly I think, that little island down south called Manhattan, where a lot of doctors weren't accepting insurance. And here in the Capital Region, in the spring, we know the largest insurance company, the Capital District Physicians Health Plan, wanted to throw out the largest oncology provider and let people die of cancer. And the other thing that I wanted to bring up, so I want you to sort of like drill down a little bit more, if you can, on the network issue, because it's really important to healthcare delivery. And do we have any evidence of businesses that can't afford the premiums that have either gone out of business or stopped providing insurance? Do we have any statistics on a drop on medical-related bankruptcies? And two more points is, do we have any information about whether the Affordable Care Act has actually affected healthcare outcomes? And then the elephant in the room, what are we going to do about long-term care?
Sounds like several elephants there. Heard. Anyway. Anybody?
Do you want to go ahead? Do you want to answer it more globally? Answer for New York?
Let me pick an elephant here, and that was the last one, namely long-term care, because this is an issue that I've been involved in over many, many years, and it in recent years has been kind of the throw up the hands issue. We know it's looming at us. There are a lot of people moving into the long-term care age group, and what are we going to do? And there have never been any answers, and efforts like the what was it called? The Class Act?
It was
Class
Class,
Act,
yes.
was to create an entitlement program rapidly become evidently very expensive, and then in that case it got repealed. My ray of hope is that within the last few months, there have been several groups that have come together, not around a big new entitlement, but about incremental reforms to the existing system that would actually help. Those, I think, are potential. If we ever get a Congress and a president that actually want to do something, there is a list of things that could be done that would help. And they include, perhaps the most difficult one, would be a federal program to take the cost of very high cost long-term care people onto the federal budget and off the states. That would help relieve the pressure on state Medicaid programs. And there are a list of other things. But I think there's some hope for constructive action in the relatively near future.
Dick?
The Class Act wasn't implemented, and that's a good subject, and your list is a very good list. Alice mentioned as a last item something I might want to hear Donna or Judith or Judy or eventually speak to, which is the Essential Health Plan. We're going to talk about that in a few minutes. Allows you to pick up some people who are really expensive and are hard to bring in. And many states have had, and there was a transition in the law to what Alice referred to, which is a high-risk pool. And there's been some talk, Mike Morrissey, our expert on health insurance, who wrote the book, I read that book a lot, and I've learned a lot about it over the years, is that if you had the expensive, call it high-risk group, in a special category, then you could have pricing more attractive to more people, and the pool would be bigger, and more people would find the bargain, healthcare bargain, affordable. But what I wonder about, Donna and Judith, maybe you could comment, or maybe you haven't thought about this, how would you do that? How would you decide that there are some people that are eligible in the exchange, but are so expensive that they cause what we've seen in many places, which is adverse selection, where prices go up because there are only expensive people in the pool.
I'm going to leave Donna to address the QHP component, but I think I come from the opposite perspective, which is I'd rather have large pools of people where you spread risk rather than take out the high-risk people and move them separately.
Why?
And I think, why? It seems like the right way to do insurance, from my perspective, is and Essential Plan's really no different in its risk pool than, inherently, it turns out it looks like it's healthier, but inherently it's no different than a Medicaid, maybe healthier than a Medicaid risk pool for sure, probably similar to a QHP risk pool. Mm-hmm. Its price point being lower than QHP's may bring in people who are healthier, who were put off by higher premiums, and now they're like, well, for this price, I'll come in, even though they still feel they're healthier. So we have that's an aspect. But I'll let Donna address the.
Yeah, I think I tend to agree with Judy that the principle of insurance would have as many people, in one pool as possible. And I think, we're sort of at a juncture here. I think that the federal law attempted to address those issues through the 3R programs. And I think most notably the risk corridor program, which, because of changes that were made in Congress that cut the funding, it cut the method for determining the risk corridor payments pretty substantially, insurers received 12 cents on a dollar, more or less. And really the objective of those programs was to spread risk. It was to make certain that health plans that for whatever reason attracted a sicker population in aggregate or individually, in the case of some of the programs, were protected against that adverse risk that came within a risk pool. So, I think as we go into this next open enrollment period, those issues are going to get rightfully a lot of attention as either the 3R program sunsets, or based on the reality of how the risk corridor program played out in practice.
Okay, well, one of the other elephants that were brought up was the issue of many providers not accepting Medicaid patients or not accepting other patients under some of the public programs, and that may be not just in Manhattan, but other places as well. Now, it seemed to me that the ACA did allow at least some marginal increases in payment levels under Medicaid. I may be wrong about that, but I don't know whether you see any progress under ACA in terms of willingness of more providers to accept Medicaid recipients, or whether you are able to know much about that, or whether you see some lack of progress. So.
I can't speak a lot to that. What I can say, because it's not my area, but what I can say is our shift to Medicaid managed care, which is not ACA related, that brought a lot more providers to the Medicaid program than the fee-for-service program. And one of the things we see on the marketplace are people, the way Medicaid works is you first get fee-for-service and then you get managed care. And there are people coming in who have relations with providers. Their providers participate in Medicaid managed care. They don't participate in fee-for-service. So we get a lot of calls asking to rush their enrollment in a managed care plan, as opposed to being kept in fee-for-service. But I don't know if that. So I know that network's larger, our managed care provider network. The new managed care regs do require that those in managed care take fee-for-service. We don't know how that's going to play out yet.
And if I could add, Tom, I know we're running a little tight on time here, but I think, Alan, the article that you mentioned in the New York Times was related to private coverage as well. Mm-hmm. I think it was related to private coverage sold on the marketplace. And, it's not going to be that every healthcare provider participates in every health plan network. We're not any willing provider state. I don't know we've ever been. I don't know that we ever will be. I mean, what we view kind of our role as, and it's our charge actually under the provisions of the Affordable Care Act, is that the networks are adequate. And one of the things that we are looking at and we wrestle with is, how do you define adequate? We're not alone in that, I think. The federal marketplace is looking at that, other state marketplaces. Traditionally, it's been in terms of the number of providers. So how many specialists, how many primary care doctors, how many primary care physician extenders, how many hospitals. And I think that we need to take a look at that going forward. I mean, what we really strive to do is, when we see those types of things, or when consumers come to us, is look into the individual circumstances. We receive electronic files of health plan networks on a quarterly basis. If there's a large change in the network, the health plan is required under the contract they have with the marketplace to report those immediately, so that we have that information that's up to date. But it's evolving. I think the way consumers think about networks is going to change, and in large part, how you view your network is sort of based on what you're accustomed to as your insurance. So more to follow. Thank you. I think it's a great question.
Well, Robert says we have 1 minute. So does anybody have one last comment up here? I don't have any more. Oh, okay. We have some questions back there. Very quick.
Okay. I think it's clear. Hi, my name is Laura Hartmark, and I was a tech writer on the exchange before it went live. Donna Frescatore was my product owner and probably the best client ever to work for, FYI. And now I'm a reporting analyst on the MMIS program or project through Xerox here in New York State. It's a kind of a homework question because I'm playing hooky to be here. My boss let me off to come see Donna talk. Going forward in the next 1 to 3 years, what Medicaid data do we need to do really well to give you the data points that you need to know where we are a year from now or 3 years from now?
Wow, that's a great question. It's good to see you. Technical writers are so very important, and documentation specialists in this process. It's amazing. For anybody who's been involved in a large system build. No, we want to know, I think, more about the application process, kind of the details of how do people start, where do they get stuck, do they stay in the program, do they change programs? This idea that people move back and forth from one program to another in the marketplace is real. In the beginning, you heard, other states say 30% churn rate, and people are moving around. You said, well, can that be? But look, this is a dynamic thing. These are like real lives that people have, and we're seeing already that people move among programs. That would be really helpful to figure out how to figure that out, because it affects the program decisions we make. It makes certain you don't lose people in those transitions. It's one of the reasons we are very, in retrospect, we think that this integrated marketplace is the right thing to do, because people don't stay in place all year long. And we've got an opportunity to help make certain that they not only get covered, but stay covered. So that kind of information, I think, is really helpful.
Yeah, I think on the utilization and expenditure side, we have a lot of robust Medicaid data, and we've been using it well. I think where we haven't done a very good job is on the eligibility data. We never could get data out of WMS. We can get a little more data out of the marketplace, but we can't get all of it together because we still have people in WMS and the marketplace. So along the lines that Donna said, but a lot more robust Medicaid eligibility data. And I know that that's not the scope of the MMIS replacement, but it is a big gap in Medicaid data that we're trying to fill through the marketplace.
Okay, very good.
Take one more and I'll find the time.
Okay, all right, we can take one more. Okay, we have two back here.
Short answers.
Okay, you guys are going to be really fast. Okay, you first, sir, and then you, sir.
I'll talk as fast as I can. My name is Bill Shapiro, and I worked in public welfare in the state social services department until they stopped paying me on a day-by-day basis. But in more recent years, I've been involved in doing volunteer income tax preparation. So from the individual's point of view, the low income or the uncovered individual, the moment of truth is when you're filing your income tax return. And there are all kinds of problems, one of which is, oh my God, I got a premium, I got more premium subsidy than I should have, and I now have to pay money back. And we're dealing with a group of people who, as recent reports have been talking about, don't have $400 for an emergency. So you're changing their tax refunds or requiring people to pay not on the basis of their tax calculation, but because the penalty is administered through the tax system. That's an urgent problem. But it brings home the salience of the coverage requirement. But by the time a person is sitting in front of an income tax preparer, the enrollment period is over. So I can make the speech and I can be very persuasive about, for only a couple $100 more than the penalty that you're about to pay, you could actually be covered in case you have an accident or some kind of emergency comes up, let alone an ordinary course of events kind of thing. But there's nothing the person can do to act on that at the moment that it's become salient. Is there any thought being given to aligning the periods a little better?
That's a great point, and wonderful work you do as a volunteer. We work with the volunteer tax preparers to help increase awareness. So the first year, we were able, along with the federal marketplace in other states, to extend the open enrollment period for people who learned they were going, to have a tax penalty. That's options closed to us right now. The actual open enrollment periods are fixed in federal rule, and they're fixed now from November 1st to the end of January. So we hear you, though, on that issue. We'd love to, have more conversations about how do we educate people who maybe have not experienced that or have experienced it once to try to get them into the marketplace. The good news that Danielle's going to tell you about when we get to the essential plan is it's any month enrollment. So people in that income bracket at least have not missed the open enrollment period. It changes the dynamic pretty significantly. And you can imagine the first year sending out nearly 500,000 Form 1095As for the first time. So there's room we have there to do that better too, and to make certain that we're synchronized with the insurance companies on enrollment, so fewer people get their 1095 and realize, wow, this doesn't look quite right. So we hear you on that.
Very good. And yes, sir. This is the last question.
Amen to that, huh?
Amen.
My name is Peter Young. I'm an emeritus volunteer CEO of Peter Young Housing Industry and Treatment. And trying, if I could, to do this, I could remember 1959 sitting in the dining room down at the Capitol with the governor, Rockefeller, and Harry Albright, and he was saying to me, knowing a little bit about what I was doing in the south end of Albany at that time, Father, what is this Harlem drug that you're working with? I said, Governor, it's not the Harlem drug, it's the heroin drug. And, I tried to explain it to him, and he said, Paul, I'll keep up the good work. But then I can remember January the 3rd, 1973, when he instituted the Rockefeller drug law, and we're happy to have that gone. But looking at back where we are now, we've had a lot of trouble being identified working with the criminal justice population. Everyone thinks because you're associated working with that kind of guy or gal that you're automatically a guilty kind of guy. I can remember first meeting a quality care guy that came to visit as an investigator with over 100 BCI and FBI to investigate me, saying, well, you're working with criminals, so you got to be one of them. It's an amazing kind of gift when you're trying, if you could, to report people in for doing a crime and trying, if we can, to get them help. We need to help these people. They're addicted. We're looking at that kind of a problem. We've been isolated by way of many of the kind of violations, I feel, that when we go to the court and we're ACOD'd a person into a care program and adjourned in contemplation, he's going in, he's mandated by the judge, and we can't get funding to guarantee that kind of payment. For that, I've given over $1 million worth of care a year, and because of that, I became what they said a criminal because I manipulated the Medicaid law. And I'm saying, oh, wait, I gave free care, and I covered it with our own foundation, and what did I do wrong? But you did a misappropriation. There was no stealing, no theft, no dishonesty, but you misappropriated the money. You used it for the poor people that didn't have any representation. When a judge is mandating it, why can't we get a guarantee that they will be paid for that kind of service? The county is a block grant county, and therefore they don't try to cover cost out of county, and we can't get that kind of cost covered. It's a very heavy conundrum for me because I have a lot of those guys. We had to sell over 50 of our 127 program sites and try to then put those thousands of people back on the street, which is a difficult kind of thing to do. So I just would love to hear how we're going to handle the incarcerated, the homeless, and the addicted. Thank you.
Amen. Amen.
I can't answer all aspects of your question, but we have been spending a lot of time working with jails and prisons to enroll. With the new adult group, there was an interest in enrolling people while they're incarcerated so that they can come out and have Medicaid coverage when they come out. We have a lot, there could be a whole session, but we have a lot of initiatives going on to enroll people and also to turn the Medicaid on before they come out so that it's actually, because right now we turn it on, but it can take 1 to 5 days. And as you know, that can make a difference between filling your prescription or not, or going to your appointment or relapsing. So we're talking about turning it on earlier so that people literally walk out the door with Medicaid and with appointments made that they, so there's several initiatives going on for the justice-involved populations, but there's other people in the health department also who can talk more about the delivery system aspects.
Well, thank you. This has been a great discussion. Donna, Judy, thank you very much. Dick, Alice, and Sarah, excellent presentation. So, okay. And now we're going to move to panel number 2. So Dick Nathan's going to be moderating this. So we're going to have Danielle Holahan come up here, as well as Jennifer Tolbert. Danielle is Deputy Executive Director, New York State of Health, Department of Health. And Jennifer Tolbert is the Director of State Health Reform at the Kaiser Family Foundation.
I know Judy, and I appreciate people who work so hard the way you do.
Do you care at the podium? Unless you want to moderate from your seat.
I'll moderate from the podium, and Danielle, and I'll leave the seat here for Jennifer. People have, I guess this mic's on, people have referred to the basic health plan and essential services in New York State. So you've been maybe thinking about what additional we're going to learn about that, and we have exactly the right people here to learn it from. Danielle Holahan is going to present and make a presentation on the basic health plan in New York, and Jennifer Tolbert from the Kaiser Family Foundation is doing research on New York, which has the biggest and most prominent basic health plan, and Minnesota. Both states are in our network, and other states in our network and other states have considered it. But I think I'm going to let the presentation start, and then I'm going to maybe have some thoughts and questions about it, but I'm not going to start with that. I'm going to turn it right to you, Danielle.
Can I use the podium? Is that okay?
Sure.
Terrific. Thank you. Maybe before I jump into the slides, I'll answer the question that came up in the last session about scorekeeping and the Kaiser analysis, and start by saying cross-state comparisons are very tricky because no state is the same. But as I understand that work, it's a QHP-specific enrollment rate, and by virtue of implementing the essential plan, we sort of, by that measure at least, don't compare across other states quite as well, but again, by that token, if it's a QHP-specific take-up rate. We see similar things when people do cross-state comparisons. I remember after having a very successful first year, there was a lot of numbers out about, progression from year 1 to year 2, and we looked perhaps not as good as we thought because other states had, maybe more challenging first year. So we'll just caution with cross-state comparisons with those two comments. Okay, so I'm going to jump in on the essential plan, what we have branded the basic health plan in New York, and do some overview, and then we'll look forward to discussion and questions. So first, this slide is really kind of some of our marketing talking points about the essential plan. We describe it as a new health plan for lower-income New Yorkers. It launched this past January. We want to make sure people realize it is as comprehensive as QHP coverage, all the same essential health benefits, but cost significantly less. And that, we've alluded to many times, is a very key component of the essential plan. Under state law, the essential plan premium costs either $20 a month, which we like to say less than $1 a day, or nothing at all. So it is truly affordable coverage. And not only that, we'll talk about some of the cost-sharing pieces as well, but that has proved to be a pretty good catch for some of our outreach efforts to be able to get that affordability point in. So eligibility for the essential plan, like all of our programs, you need to be a resident of New York State, lawfully present. Age eligibility, it's for adults, it's ages 19 to 64. And income, as I think everyone knows, goes up to 200% of poverty, but for the premium piece, it's free up to 150% of poverty, or $17,655 a year, and $20 a month for those between 150 and 200, so up to the $23,000 a year. You're not eligible if you're eligible for Medicaid or Child Health Plus, and like the tax credits, if you have access to other affordable coverage, you're not eligible for the essential plan. There we go. So we did, again, like our QHPs, we standardized benefits for the essential plan. So they all offer the same standardized product benefits and cost sharing. Importantly, there's no deductible for any of the essential plan products. As with all products, all preventive care is free. And a few examples of the low co-payments. For the highest income piece, the group that's between 150 and 200% of poverty, the cost sharing is $15 for a primary care visit, $25 for a specialist, $6 for prescription drugs. And so this is significantly more affordable than comparable QHP was just the year before for someone who's transitioned. And then vision and dental coverage is available at an additional premium. So that's an option for the higher income groups. And of course, for the lower income essential plan folks, that's included in their package. This, I don't know if anyone can read this, but we have this on our website. It's meant to be a high-level overview of the cost sharing across the different essential plan programs. But I will say for Essential Plan 3 and 4, which are the lower income groups, there's virtually no cost sharing at all. When you move down to the drugs, you start to have a $1 or $3 copay for drugs. And then the next tier up, same thing. I think there's really no difference at that tier, and then it's really only the highest income tier that has some cost sharing. So it truly is affordable, significantly more affordable than QHP coverage. On the insurer participation, 13 health insurers participate in the essential plan. Importantly, as we talk about the integrated marketplace, 11 insurers participate in all of our programs, so essential plan, QHP, Medicaid, and Child Health Plus. And we think this is very important for, as we know, people transition, or maybe even within the same family have different people eligible for different programs. So having that high level of insurer participation across all programs is very helpful in promoting continuity of care. This slide is a look at all of the insurers that participate in marketplace programs, and we've circled the 11 that participate in all of our programs. And for those who are familiar with the health plans in New York, it really is a combination of the plans that were traditional public program plans, traditional commercial insurers, and the like. And as we talked about in the last session on the network piece, I mean, we have the same, because this comes up a lot when we talk to folks about the essential plan, the same network adequacy requirements of all of our products and strong overlap when we compare the QHP networks and the essential plan networks. So when we talk about implementation, I again think this has been alluded to a number of times today. This has been very successful. We describe it as a win-win for both consumers and the state. On the affordability piece, on average, when we had Urban Institute do some estimates for us of some different elements of the essential plan, and when they costed this out, it is on average $1,100 less expensive for someone to enroll in the essential plan compared to a qualified health plan, just the year before. And so that really speaks to not only the premium, but the out-of-pocket cost, which is really quite significant. And for the state, it's truly a win for the state as well financially, and is what enabled us to be able to offer such a robust package, is that state savings exceeded $1 billion in state fiscal year 2016, and that's truly because we're able, of where we started. And this, I know Jennifer will speak to this as well, about Minnesota started from a similar point, covering legal immigrants within their first 5 years with state-only money, so that was in our state Medicaid program. We had that starting point, and we could leverage these federal savings in order to develop this essential plan and make it quite as generous as it is. So a few comments on enrollees. Again, we think consumers really do love this product, and that is shown when we look at our conversion rate of people who come, fill out their application and get an eligibility determination for coverage. 98% of those who get to that point go on to select a plan and enroll. That is significantly higher than the conversion rates we see in other programs, QHP, Child Health Plus, and the like. And I know we've alluded to this too. What we're seeing early on is that on average, the essential plan enrollees are younger than the residual QHP enrollees. So that we do think we are penetrating into that young adult group, and we are penetrating with new people, and I'll speak to that. This didn't quite convert too well, but what this used to say is that essential plan enrollees are really made up of about 40% were former Medicaid enrollees who transitioned to the essential plan. Another 40% were former QHP enrollees who transitioned to the essential plan. And then that remaining 20%, that's yellow, are new to the marketplace. So we really are seeing that we are reaching new people with this program. And again, it's that conversion rate, and it's the affordability piece. So we really think that there's new evidence. It seemed obvious to everyone, but the researchers that we work with are so excited that there's actual evidence of people faced with an affordable option. The take-up rates are just, so much better than they have been in traditional programs. What we see when we compare last year's QHP composition to this year's is a change, as you would expect. Traditionally, we had 3/4 of our QHP enrollees were enrolled with tax credits. Now that we have moved the share I talked about that moved from QHP now into the essential plan, 54% of our QHPs are enrolled with tax credits. So that's, as we would have expected, but a different composition of the residual QHP group. And on the financial implications for the marketplace, as you all know, the administration of BHP is funded by the state. And one of the other choices that we made in New York was how to finance the marketplace, which I do think is different than a lot of other states that have a per member per month fee on QHP enrollees that their sustainability formula is premised on. We do not have that in New York, so the fact that our QHP numbers have come down has really not had an impact on marketplace sustainability. So I think that's an important policy choice as well. A couple of the other implications for operations of the program, we had choices to make and one of them was year-round open enrollment. So we don't have this, this is a pretty fundamental shift for the marketplace, where we had been so focused on a 3-month open enrollment period, where that was where all of our outreach efforts and advertising were focused. That's not the case with the Essential Plan, which really changes things quite a bit. Not only do we have more people who can enroll year-round, there's less special enrollment period enrollment, which I think is a positive. We decided to do our advertising year-round now, because most people who apply through the marketplace are coming into a program that they can enroll in year-round. And on the tax question, which I know was raised earlier, there's no individual tax reconciliation on the Essential Plan either, which I think is a positive for consumers as well. That's done at a state level for the Essential Plan. So I think in conclusion, we really have found this program to be enormously exciting, enormously successful. The enrollment has already met our expectations for year end, and we continue to see it every day. So consumers are excited about it. The state is excited. And it's early. We'll continue to evaluate what the enrollment looks like, and whether we continue to reach into these populations that have been harder to reach. But we're very optimistic, I would say. The early results are quite promising. And I will leave it there.
Thank you very much, Danielle. This plan, Basic Health Program, is under Section 1331A. And the only other state that's adopted it, although some have considered it, is Minnesota. And Jennifer is studying the 2 states and has studied what other states went through in thinking about whether or not to do this. It surely does look like a good deal. Paul Krugman wrote an article in the New York Times a while back, said, you don't realize how successful the Affordable Care Act. And then way down in the column, he says, but it's somewhat underfunded. And what you're seeing here is that this is a very attractive, more funded plan, and a lot of people are coming into it. That shouldn't be a surprise. So I keep asking Jennifer, and we've had this conversation. Jennifer, you go to the podium now. Tell us what we should think about in terms of the implications of this and what it means for the ACA and for not only Minnesota, but for other states too.
Okay, so you want me at the
podium?
podium?
Sure, I think so.
Okay.
All right.
All right, well, thanks, Dick. So before I talk specifically about the Basic Health Program, and I'm going to move this down just a little bit so I can see over, I want to talk a little bit about the reasons why we need to be talking about Basic Health Plan and other options, and that is because the affordability, as we've discussed earlier, affordability of marketplace coverage is a growing concern, and it's a growing concern across all states. And so here at the Kaiser Family Foundation, we've undertaken a number of studies to try and get at, the experiences of individuals with marketplace coverage, what the affordability issues are. So we've done this through quantitative work as well as a number of focus groups with marketplace enrollees in 10 states. And what we're finding is that over time, marketplace enrollees are becoming less satisfied with the premiums and, most importantly, with the deductibles and out-of-pocket costs associated with their marketplace coverage. We're seeing that satisfaction drop from 2014 into the latest round of our survey, which we just released a couple weeks ago. In addition, as they're becoming less satisfied with the cost sharing, they are also reporting feeling more vulnerable to high out-of-pocket costs and high medical bills. And that's as they are using services, now that they've been enrolled for a year or two, and they're actually using care, they're finding that the cost of that care is becoming less affordable to them. And although we didn't, unfortunately, I would love to, wish I could report on focus groups that we did here in New York, but we did go to 10 states, not yet to New York. Hopefully we'll be able to do some focus groups here soon and report back to you all on what we hear. But what we've heard, and it has been a consistent theme across all of the states in which we've held these groups, is that marketplace enrollees are feeling very burdened by out-of-pocket costs in particular. They find again, most of these folks are receiving premium tax credits. They know that monthly premium, they can budget for it, and even if it is high, they're making room in their budgets for the premiums. But what they can't seem to afford are the out-of-pocket costs associated with the deductibles, particularly higher deductible plans, but also coinsurance and cost sharing. And, and for those of you who've worked in the private insurance market for a long time, this comes as no surprise, but people are getting hit with unexpected medical bills when they use services. And that's either in part because they don't understand the deductibles and how they're structured, and sometimes in cases where they're getting billed when they shouldn't be. And so that's an issue that we have to address. But one of the advantages of the Basic Health Program Essential Plan, as it is called here in New York, is that you can eliminate and get rid of those deductibles, as New York has done, and I think that will go a long way to addressing these affordability issues. But again, in terms of looking broadly at Basic Health Program and the feasibility of adopting this across more states, to date, only 2 states have adopted Basic Health, or BHP, I will call it, Minnesota and New York. And a foundational issue in both states is that they both had pre-existing programs that predated the ACA that made the adoption of the Basic Health Program feasible. In the case of New York, it was the state-funded Medicaid coverage for the immigrants who hadn't yet met the 5-year, hadn't been in the U.S. yet for 5 years to qualify for Medicaid coverage. In Minnesota, there was a long-standing commitment to health coverage, and they expanded Medicaid through an 1115 waiver called the Minnesota Care Program. And so, in Minnesota, the adoption of BHP was a way to enable that program, Minnesota Care, to continue. And in New York, the advantage of BHP was to provide a better product for consumers, but also to save money on that state-funded coverage for the immigrants. So we are currently engaged with our colleagues at the Urban Institute in a study of implementation in both New York and Minnesota. And so I should caveat what I'm about to say, that my findings all here are preliminary because we haven't quite finished our interviews. But a couple of key themes have come out of our work so far. In addition to having these programs in place, plus a strong commitment to coverage in both states, another key factor in getting a BHP adopted is broad stakeholder support. And this was within the legislature as well as across all of the key players in the healthcare sector. And the role of advocates in pressing for the adoption of BHP. And Elisabeth, you'll be happy to note that in talking to the folks in Minnesota, they said that New York was instrumental in helping them get their BHP program adopted, because it was through a conference where they met Elisabeth and talked about it and crafted the message that eventually sold the legislature on getting a BHP adopted.
It was really Al Franken cornering Obama.
Okay. Well, however it came about, but I think New York played a role. But yes. I will also say that concerns over the impact or potential negative impact on the marketplace that have been voiced in other states just simply weren't an issue either in New York or Minnesota, and that helped kind of get across the finish line with BHP. In terms of implementation, a few key factors, one of which we've discussed already, is having an integrated eligibility system is critical to making BHP work. Because as we've talked about, you've got people moving from Medicaid into BHP and into QHPs and back and forth. And so you need a system whereby people can go into one door, apply through one portal, get determined eligible for the right program, and placed into that program in a very streamlined fashion. New York has that. Minnesota is struggling. Their system isn't quite working as well as it should, but but they are getting there. In addition, having alignment of health plans is also critical, again, for ensuring that continuity of coverage. We've talked a little bit about the enrollment. We've seen enrollment increases, obviously pretty significant in New York, but also in Minnesota. They had 80,000 people enrolled in Minnesota Care in 2015. They are now up to 120,000 as of the end of the third open enrollment period in 2016. So again, enrollment is increasing, and these programs are consumers across the board are pleased with these programs and appreciative of the lower costs and the fact that there are no deductibles that they will face. The one area where I think there may be an issue with replicability in other states, and that comes down to program cost. We heard from Danielle that obviously New York realized $1 billion in savings because of the movement of the immigrant population into BHP. But when you look on an ongoing basis, because the benefit package in New York is so generous that on an ongoing basis, the 95% federal financing, so 95% of what these individuals would have received in premium tax credits and cost-sharing subsidies that gets paid to New York, isn't fully covering the cost of the program and the benefits. But the savings were so huge from moving the immigrant population that it was clearly hands down the way to go in New York. Minnesota is experiencing the same thing. Federal funding in Minnesota is only covering about 42% of program costs for the BHP. Now, like New York, Minnesota has an existing or a long-standing healthcare access fund that is funded through a provider tax, and so they are using money from that fund to support the cost of their program. Elizabeth, you're looking at me funny. Is it a little bit? It's not quite.
I was just curious what our 42% is, what our version of that is.
Yeah, I don't. Right. So I think when it comes to other states adopting BHP, this issue of financing is going to be a tough hurdle to overcome, and it may mean that BHP, as it stands, may not be an option for other states, but there are some alternatives. So instead of leaving you on a down note, I want to talk about the fact that there is another option out there that states are considering, which is the 1332 waiver option. And this is broader than BHP, and even Minnesota, they have a task force and a series of recommendations that is suggesting that they move their BHP program to 1332 as a way to further expand up the income scale, the high level of subsidies that they are providing through their BHP program now. And so that is an option. I think the outcome of the election is going to determine a lot whether 1332 is going to be available to states. But anyway, I will leave it at that. I know I took more time. I'm sorry, but hopefully we can have a discussion.
Jennifer, both of you, those were terrific, clear, important presentations. And I want to add an element. We talked about this a little bit today at lunch, which is that the administration of a law, when you implement a law, is very important because inside of government, they have to make rules and interpret the law and decide, can we do this? Can we do that? And the Congress is now, members of the Congress on the Republican side are challenging the authority of the Obama administration. And I heard the president on public television the other night, he calls it Obamacare all the time. He's very happy with that. But the Republicans are saying, you don't have the authority to do this. You don't the authority to do BHP, that, but also the authority even bigger to pay for cost sharing, which is authorized in the law but not appropriated.
Right.
So we're looking at some very subtle questions of how the government, people in the government wanting to do this, are doing it they're being challenged. There's a court case on the cost sharing, but there's a big question as to whether the Congress, which is members of the Congress are taking this case, whether they have standing. So when you think about what this election is going to mean, it's going to get down into deep things, deep questions about who's administering this law. And it may be that things are happening, some things are not so good, some things pretty good, some things very good, and that CMS and people in government, there was a big debate inside the government. Somebody at OMB said, no, you can't do this, and they had a big a session with top policymakers and said, don't talk about that anymore. So this is not just a matter of looking at the law. It is a matter of looking, yes, at the behavior of markets. We, Alice and I, we really want to do that. Are there competitive markets? And is there affordable, adequate care in competitive markets where the ACA is working? And what kinds of things make that happen? Maybe, and of course, Danielle, the BHP in New York is really helping you. And you have to think about, as I just said, what is at stake here is not only changing the law and implementing the law, but interpreting the law. And Tom will hate me for saying this, but from my experience deep in government, I wrote a book on administrative presidency, how making rules like this is not just small potatoes. This is a big part of what the last piece of the American safety net is healthcare. And we waited so long that healthcare is so expensive in America that we are doing it, but it's hard, and we're doing it, as Alice said, piecemeal in pieces, and there isn't another way to do it, in my opinion. So now I've used some of my minutes, Bob, partly to comment and partly to stretch the canvas a little more. And what I'm going to do is ask both Danielle, they did a wonderful job, and Jennifer, if there are things you'd like to add that maybe should be covered, but because this is only a 15-minute panel, we're just going to have to let them speak and continue on, Bob. I don't think, Rick, you can ask them questions later. They've done a good job. Do you have things you want to add, Danielle, particularly in light of what I said or what Jennifer said?
Sure. I mean, I can just comment on your comments there. I mean, I think, as we've said all along with the implementation here and many challenges and along the way is that, we're focused on implementing what we have, and it's the law. And, until it gets overturned, I think we've had a good track record too, and I don't want to jinx anything, but that things have been upheld and will continue to carry on. So with optimism, I'll say. But so I mean, that's how I would respond to the comments there. I think one thing that you said I thought was interesting on the Minnesota, truly the share of the 95% of the federal payments do not cover the full costs, certainly of a rich basic health program or the essential plan. I was just pulling out the page in the budget here. I'm not going to do quick math, but it's certainly not all of it, but it's nowhere near 40%.
Okay, that's good.
So I think the 2016 numbers were the total program cost just under 2.5 million, and the federal payment covering almost 2.1. So we obviously
Let me expand the question to you, Jennifer. When you talk about Section 1332, everybody knows what that is, and it goes back to the comments I was making. What happens to Section 1332 depends a lot on the election, not just the president, but the Congress, so I'd like you to comment on what Danielle just said, and maybe comment on my expansive remarks about how inside the government this is all very complicated political terrain.
Yes, well, it most certainly is. And I will say, I think perhaps the reason why the costs in Minnesota are fewer of the fewer of the costs are covered is because Minnesota had among the lowest premiums in their marketplace, and that plays a factor in the level of subsidies that are received. So, but I'm glad to hear that the program costs or the federal financing is covering a larger share in New York, because that does bode well, because that's, if you only have to get 15% from the state perspective, that's much more doable than 58%. So that's, and I will make sure.
58% refers to what now?
In Minnesota. So in Minnesota, the state is covering about 58% of the cost of the BHP.
Even with the 95%? Mm-hmm. Okay.
Yeah.
Everybody got this?
Again, preliminary, and that may change. Wait for the report, which will be out in July, where we will document this more fully. But the preliminary data is suggesting that. So, and in terms of Section 1332 and the politics, the ACA has been caught up in politics since it was enacted, and this latest round, the lawsuit around the cost-sharing subsidies is troubling. We can hope that, as has been the case with the previous litigation, that ultimately the authority of the administration to implement this law the way they have will be upheld. But yeah, I think when it comes to the Section 1332 waivers, the idea behind these waivers was to allow states to experiment even further beyond what was included in the ACA, to try and broaden coverage, to provide more affordable coverage to consumers. And I think there's an opportunity for states to do that. Again, assuming that there is a president in the White House who is supportive of continuing the ACA and open to kind of state experimentation, because I think states like New York, which have always led the way in terms of providing coverage and providing affordable coverage, can come up with some really innovative ideas to expand this further and address the affordability issue.
This is not a political meeting. And Jennifer, thank you for coming from Washington and giving and helping me and helping all of us think about what Danielle is doing and New York is doing, and it's working in New York, and what the future holds for all of these questions, great questions that have been raised by the audience and in the presentation. So I've overused my 15 minutes for this panel, and what? You had 30. I had 30, and we used 30? Yeah. Oh my goodness. Okay, we're finished.
All right, well, it's wonderful to still see many people here. Their third panel is the Exchange Enrollment Hurdles, Rural and Urban Navigation Assistance at Local Levels. It's going to be moderated by Elisabeth Ryden Benjamin, Vice President for Health Initiatives, Community Social Service Society in New York. So, Elisabeth, you may come up, and you're going to be joined by Lona Cook, Lana, Navigator S2AY, what's that stand? SAY2. Okay. Rural Health Network, and Rehan, is that correct? Rehan. Rehan Mehmood. Okay. Director of Health Services, South Asian Council for Social Services. So, thank you. I'm sorry for messing up everybody's names, but please go forward. Thank you.
We put together some slides. They're coming. So, good afternoon, everybody. Thank you for being the vigorous few to hang in there for this presentation. I'm really excited, and thank you to the Rockefeller Institute and to Sarah for the amazing paper. And it's really a thrill to be here, and I know I speak for all three of us. I wanted to just sort of quickly, does this? maybe I have to turn it the other way. Okay, so I just wanted to talk really quickly about navigator services in New York State. You know, our state is incredible, thanks again to the leadership of Donna and Judy, and an amazing woman in Judy's shop named Gabrielle Armenia, who has really been a fearless leader, first facilitated enrollment, which was sort of the precursor program for navigators in New York State, and I think really was sort of one of the sort of models for why we have navigator programs in the Affordable Care Act. But our program at CSS, although it's the largest, there are 47 other great navigator groups in New York State. Gabrielle Armenia, when we were launching the Affordable Care Act, would get on the phone every single week with us, and people would complain and tell them this and that. But it was real-time feedback for the marketplace, and I think it was really helpful. And everybody was doing it because we were so excited to be part of this project. And bless the State Department of Health. When I go around the country and talk to other advocates, whether they're from Minnesota or elsewhere, no one else had a marketplace that was willing to talk to enrollers every single week in a meaningful way and get feedback. And I think that really was a testament to the incredible success of this program. So just quickly, our program is in 61 out of 62 counties. We didn't get Chemung. I always think it's Broome, but we didn't get Chemung. That was a bummer. We really tried for Chemung. Our network, like navigators in all our sister agencies. I mean, Stacy Villagrand, right there behind Donna from Nassau Suffolk Hospital Council, amazing navigator out in Long Island, a real partner to CSS on a post-enrollment grant that we have working on post-enrollment consumer assistance is just amazing too. But what navigators are is we're free, neutral health insurance enrollment assisters. So people can come to us and, we're not selling anything. We don't get a commission. We're just neutral, and we've been trained and certified by the New York State of Health. We're all on the same playlist. You should not experience a lot of variation, except in important ways when you go to a different navigators. As you can see, we serve diverse populations in our network, but this is true throughout the navigator program in the state: low-wage workers, immigrant communities, people with disabilities, workers, young adults, children, LGBT people, self-employed people who can have very tricky applications. And so that's why I think navigators are especially important for the self-employed. Farmers, as Lona will talk about, it's really helpful to go to a navigator and work through the application process. And Stacy and I and anybody here can tell you the war stories about doing it. The other great thing about navigators is that we speak in our network alone. It's 23 languages. I think it's roughly 50 different languages are available around the navigator program statewide. It's amazing the amount of languages, and it really, as Rehan will talk about, it really makes a difference to do enrollment not through a translator service, to have it real time. It's much more efficient, much more satisfying for the consumer. Now, to talk about the urban perspective is Rehan, and he will talk about some of the issues, opportunities, and challenges we have. And then we're going to talk from the rural perspective from SETU will be Lona, and the opportunities and challenges. And I might be flipping back and forth from these two slides because I think they'll be hitting these points. But I thought I'll stop talking and we'll have it be a little more conversation. So I personally have enrolled 250, 270 people. I want to tell you that is nothing compared to what these two have done. Rehan, how many people have you enrolled in the New York State of Health?
I've assisted over 1,700 individuals and families through the New York State of Health. And
how many was that?
1,700 through the New York State of Health. And I don't remember the count of calls that we have received and talk to people about the New York State of Health over the phone.
And Lona, how many people have you enrolled, would you say?
On my dashboard now, I think there's about 1,300. I've, started at the beginning, so some of, they transition back and forth, but as of now, there's 1,300. Can you hear me? Okay. I know. Thank you.
We can hear.
Thank you.
And
1,300.
And Lona, you have a little bit of experience doing this before the Navigator program, right?
Yes, I was a facilitated enroller with the SETU Rural Health Network starting in 2001. So I've helped the Medicaid applications, Child Health Plus, the Family Health Plus.
We'll stay with you for a second. So talk a little bit about the community you're working in. It's Steuben County?
I live in Allegheny County, and I do Steuben County, yes.
And what's it like in Steuben? What are your clients like there?
It's small. They're young, part-time workers. Not many of, most all of them are not offered health insurance. I have a site at a local hospital there that I see a lot of people from.
And what do people do there? What are they? Dairy farmers?
They work in restaurant, they're restaurants, and they're self-employed. There's farmers. There's a little bit of everything.
And Rehan, you're from the great county of Queens, which would be our most diverse county in New York State, I believe. A few 180 languages, I think, are spoken in Queens. What's it like in Queens? What are your clients like?
So we have heard that Queens has over 180 languages. So the languages that you saw on the slides, 30 of those, our navigators speak 11 languages out of those 30 languages, and I speak 3 languages, South Asian languages. So we assist clients with coming from various backgrounds, mostly our immigrant community. So they have their own cultural values and languages. So our navigators speak all the major South Asian languages and also Spanish. So it's like it's a combination of cultural competence and language assistance. So it has been a great experience, and every day we see different clients coming with different aspects and raising different questions about the New York State of Health. So it has been a great experience. And Queens is like, it's a diverse island. It's a place where you see, I think the whole world lives in Queens. So yeah, so you have everything everywhere, all religions, all communities. You can go anywhere, but like it is best to be a navigator and at the same time have the cultural expertise and speak multiple languages, so that it's easy for people to understand and it's easy for you to help them navigate through the system. So that's why, I was able to assist 1,700, and yeah.
And to get those 1,700 clients, and your organization has done many, many more. I think we do altogether around 55,000 enrollments in our network a year. Where would you go? Like, where do you go to find people? Because do people always just walk in or call you, or do you actually go out to the places to see them?
So we go to different community centers. Mostly religious organizations, faith-based centers like mosque, gurdwara, temple, whether it's a Hindu temple or it's a Sikh temple, and also to different community centers. Queens has a lot of community centers around at different corners. So we do go there, and then we also the best part of the Navigator program is, as I said, the language. Because if I speak English, a person whom I'm assisting speaks Punjabi, which is one of the major South Asian languages. So it won't be easy for the consumer to understand the whole system. So you have to speak his language. So in order for a navigator to assist the consumer, he has to have the understanding of the language that he speaks. So we have tried our best to have all the navigators who speak different languages, and they go to different religious organizations and faith-based centers and community centers where the language is spoken. So for example, if we go to Gujarati Samaj of New York, which is a community center for people who speak Gujarati, and Gujarati is a very well organized and like a large community living in Queens. So a navigator who speaks the language, who speaks Gujarati, will go down there and then assist the clients in enrolling through the New York State of Health.
And Lana, where are the different kinds of places? Did you already talk about where you go?
I go to hospitals. I go to doctors' offices. We have libraries, town halls. So wherever because we try to do it where we're rural, so we don't go to like one big city and sit. We try to get where people are,
Right.
where they can't get there. We have.
What do you think the biggest barriers are for your clients in terms of being able to, why do they need you? Why can't they just go online at home and sign up?
Yeah, a lot of people that I see do not have email. They don't have computers. They don't have internet. They don't have access to any of that type of stuff. Transportation sometimes is an issue for them to get to us. Most families are maybe one vehicle. They have maybe one vehicle so they have to wait, for a ride or something to that aspect. So.
Do you want to tell us a story about someone that you've enrolled? Maybe just to make it a little more real for people.
Sure. I had the B family in March of
B initial we're not using, just so you guys know. No HIPAA violation.
In March. And they, family dairy farmers. There was 3 of them all together. There was 2 brothers and one was their son. They had health insurance through a small business, Agri, I believe it was.
It's Agri-Services.
Agri-Services, and they're for farmers. It cost them $830 a month per person with a $5,000 deductible. This to them was no longer affordable. They did it as long as they could to have the insurance. So when they come in to see us or to see me, we sat down and I assisted all 3 as individuals, and they all were actually eligible for the Medicaid. So it saved them a ton of money. So they're all, were able to stay in business and to have health insurance. So that was just
I think
one
that's
of
a
my
really
stories.
important story because it shows the sort of interesting way that tax code overlaps with the ACA. So if you're a self-employed person, you're kind of, there's sort of a net post-deduction income that knocks you down that can easily make you eligible for Medicaid or the essential plan. And it really, in Manhattan, our version of farmers are, the chattering classes. It's entertainment, it's, intellectuals, it's writers, it's artists. And those guys are always just thrilled to either be eligible for free Medicaid or essential plan for the most part. So it's been a real game changer for people with self-employed income. I'm sure Stacy behind Donna has her own version of that. I know Rehan probably has a few taxi drivers where that's been, I know we get a bunch of taxi drivers because we have an arrangement with the Taxi Worker Alliance, and there's a lot of folks that are eligible for this. Do you have a story you want to tell us?
So can I share 3?
Yeah, sure. Do people have an appetite for human stories after all this policy work, or should we stay with the policy? I know that's just late afternoon. There's not enough tea in the bag. Okay.
So I'll share the story of my first client, the first open enrollment period. We started hearing from different sections of the healthcare that ACA is very confusing. You'll get it will be a tough time for navigators to help people get into the system. It was challenging for us. So this first client that I got, he had pre-existing condition, arthritis, high blood pressure, diabetes. So he came into our office with a bunch of documents that had all the medications on the documents. So we had to go through the whole plan system and go through each plan and call each insurance company and get through everything. He told me that the insurance that he had, can I name the insurance company?
Sure. Can you name the insurance company? Is that okay? Yeah, go ahead.
Empire Blue Cross Blue Shield, the plan that he had before the marketplace, like outside the marketplace, he was paying $1,100 and some cents just for his own insurance, and then there was some deductible. So we went through the whole system, and believe you me, at the end of the application, he was able to select a platinum plan with zero deductible and paid only $156. So this was the first client. It made me happy, and then I accepted the challenge that ACA is not confusing. Whatever people say, the policy people say, or the legislators say, it's not confusing. It's a challenge. So but we learned a lot. The start of the open enrollment period, I was clean shaved, and I grew up a beard by the end of the open enrollment period.
How did you do that?
So the client had an income which was through which he was. I don't remember the exact income because it was in 2013. He was eligible for tax credit. He used his full tax credit, and then. And like there were questions about tax. So what we do is like we tell the clients beforehand that you have to remember one thing. Whenever your income changes, make sure that you change your income with the marketplace, with the New York State of Health. Call the helpline, call your navigator, and change your income, so that by the end of the period, when you file your tax, you don't have trouble in like paying the state back whatever you were not eligible for, or just like going through the hassle. So it was the tax credit that he received, and he used his full tax credit, and at the end he was able to pay $156 for the same plan, for the same Empire Blue Cross Blue Shield plan that he had before, paying $1,100. He was paying $156. The second client that I had was a couple. They also had a plan before the marketplace. They were paying $1,500 for the couple, and then there was $5,000 deductible. The husband had to go through a surgery which he kept on postponing it because of the money that he had to put in, and because of the limited resources that they had, they were not willing to go into the surgery pattern. So he applied, got the tax credit. Income was he was eligible. The couple was eligible for silver and cost sharing reduction. They were able to get plan Metro Plus silver plan, and the premium that they paid was $76. And after 8 months, I received a call from him, and he said that he was so happy that he started crying. He said that the summary of services that I received from the hospital, the surgery went well, everything was okay. I was waiting for the bills, and the summary that he received was $500,000, out of which he was only asked to pay $353. So this was the second. And the third was a client who came in and started cursing the system. And I was certain that she might throw something at me, and she was just like like we call it Obamacare. So this Obamacare is nothing, and it will make my life hell. We went through her application. It took a month because of the complications in her income pattern, and this was just like the start of the open enrollment period. We were also learning. So everything, at the end of the day, she started crying. Why? Because she was paying zero premium. The whole premium was covered by the tax credit. Her family size of 3, paying zero premium, and now she is enrolled into essential plan. So this is how critical Affordable Care Act and the Navigator program is for the consumers. The best part is, like, we spend almost for a client who is like we call difficult clients. So we spend like 3-4 hours explaining them everything, making sure that they understand the system, making sure that they understand the whole Affordable Care Act, making sure whatever is related to their coverage. We tell them about the whole system, how it works, the insurance system works, and then the plans they have. And out of 1,700 and all the clients that I have assisted, I've never seen anyone go out of our office shouting at the system. Everyone has been satisfied. Yeah, so it has been a great experience, and still there are lots of stories. I think it'll take you a full day. So
for all of those of you who've ever grew up watching All in the Family or Taxi, it's based in Queens, right? That's amazing, right? That people come out happy. It's a big challenge for New York City. We're tough. So it's really been a great thing. Lona, I thought you had one last client that we might want to end on, I think, y'all can read the slides. This is just what's so great. You see, you hear what's so great about the Navigator program. It is complicated. There are a choice of 97 plan options in New York City. That's a daunting number of anything to go through. And choice is good. I'm not saying it's just a lot, and people really want to have their hands held through. You think it's 96? You quite no. Anyway, it's a lot, and so it's really helpful to be able to go through this with folks, with a person that can really tell you the difference between the different products, different plans, different tiers, different cost tiering, and that's really exciting. I think the other thing that we all would say is having the one-stop shopping integrated marketplace that Donna was talking about at the beginning really matters. It's amazing. We're so proud of New York State of Health and the bureaucrats that set that up. I mean, God bless y'all. Because that was a lot of work and you guys pulled it off. And so I think we'll end with Lona's story because I think we're at 2 minutes and she's a quick talker. Yes. But it's nice to end on just how beautiful these stories are.
My other story, I guess. I had a lady, she was 59 years old, married to a 65-year-old who had Medicare. She was a factory worker for her whole life, and being on her feet 8 hours a day, she had some pre-existing conditions, and she had insurance through work, and because she was sore, sick, whatever, she went on medical leave. With the medical leave, they would only keep her on medical leave for, I don't know the time frame, X amount of time, whatever. And if she was going to stay on medical leave, they were going to disenroll her health insurance through work. They wouldn't continue it. COBRA was going to cost her $602 a month. They had a farm, and so she was, she had to work to have the health insurance, basically. She decided to leave her job because she just could not do it anymore. Come in to see me, and she was enrolled into the Essentials plan. So her husband remained on the Medicare, and she got the $20 a month Essentials plan.
So that's it for us. I just wanted to say one last thing in closing, that today is the 15th birthday of the Alyssa case, which the decision was handed down, I think, June 5th, 2001. And what cost the state $1 billion now reaps the state $1 billion. And so it all worked out. Anyway, thank you all very much for having us.
That was good.
Oh, good. Yeah,
All right, we're going to be very brief, but before I say anything, there is a taxi for somebody who's waiting for a taxi for a 4:05 train. If you're waiting for that, go downstairs right now. So it is available. We're going to just say a couple of things. So, Donna, do you have any thoughts, or you want to?
Sure. I'll be very brief. Thank you so much for Anita.
Oh, right.
I'll take it back. That's okay.
Oh, I can't take
the train was for Danielle, who sends her apologies that she needed to skirt out a few minutes early. But just on behalf of the marketplace, on behalf of everyone, thank you to everyone who here today. But we'd like to thank the Rockefeller Institute, Brookings, the Fels Institute. Sarah, our thanks to you. And others. Thank you to our navigators. Great stories, by the way. You give the program a personal face. You are our representatives in the community. You're who people know. When I call them, they don't know who I am. When you call them, they know, and that's what's most important. So again, thank you for the research. Thank you for the trip down memory lane a little bit. And thank you for challenging us to think about the future. Very appreciated.
Thank you. All right. Well, we usually get smart, knowledgeable, thoughtful, interesting people to talk at these forums. Today, we really outdid ourselves, so I want to thank all of our panelists today. It was an absolutely wonderful discussion. I also do want to thank our staff. Michelle Charbonneau, Mike Cooper, Joe Chamberlain, Patty Cadret, and Bob Bullock for organizing this thing and making it happen. You guys do a great job, and we always appreciate it. The only other thing I have to say is that, I'm a scholar like some of our other scholars here of federalism. And usually we think about federalism as a pretty fragmented, rigid sort of institution. Sometimes people use the term picket fence federalism, with there's almost like there's silos that don't interact with each other, that operate from the federal agencies and congressional committees down to specialized agencies in the state, down to individuals' localities. This hasn't been interesting. I mean, this is one area in which New York State is showing that you can take a fragmented federal system with a lot of different kinds of authority and different pools of money, and actually pull it all together, integrate it, and make it work for people, even down to the local level, as we saw just in the last panel. There's a lot of issues to deal with, and a lot of problems that have to be worked on, and it's still a long way to really reaching all the people we need to reach. But it is a very impressive effort, and it just shows that what a talented state agency and people can do, and local people can do, if they actually work together. So I want to thank everybody for this very illuminating today. Thank you.